Abnormal vaginal discharge and pruritus vulva or vulval itch are some of the commonest complaints that gynecologists encounter. A normal vaginal discharge is clear or white in color, odorless and non-itchy. This will become more stretchy, akin to egg white, peri-ovulation, and thicker and slightly yellow during the luteal phase of the menstrual cycle. Any change from this normal pattern constitutes abnormal vaginal discharge. Physiology of normal vaginal discharge. In young girls, the vagina is lined by a simple cuboidal epithelium with a neutral pH. After puberty under the influence of estrogen, the vaginal mucosa is lined by stratified squamous epithelium. The lactobacilli in the vagina act on the glycogen released by the shedding vaginal cells to produce lactic acid and hydrogen peroxide, which helps to maintain vaginal pH between 3.5 to 4.5. This prevents multiplication of pathogenic organisms. After menopause, atrophic changes occur due to the loss of estrogen, and the bacterial flora is similar to that of the skin, with the pH rising once again to a neutral level. Pruritus vulva is also a common presenting complaint among women, and it refers to persistent itching of the vulva, which causes distress. About 1 in 10 women consults a doctor about persistent vulval itch at some stage of her life. General skin diseases or medical conditions like the following can manifest as pruritus vulvae: psoriasis, intertrigo, scabies, contact or allergic dermatitis, abnormal vaginal discharge or vaginal infections such as thrush or bacterial vaginosis, nutritional deficiency, psychosomatic disorders, products like deodorants, perfumes, scented shower gels or soaps, or menopause with a lack of estrogen leading to vulval atrophy and dryness causing vulval irritation. Lichen sclerosus is one of the commoner causes of vulval itch in older women, but can also be found in younger women. It is a chronic lymphocytic-mediated dermatosis characterized by epithelial thinning, inflammation, and distinct histological changes in the dermis. Lichen sclerosus is associated with personal or family history of autoimmune disorders. Clinical features of lichen sclerosus include chronic pruritus, pain, soreness, and dyspareunia. On examination, the anogenital area has typical atrophic shiny white plaques in a figure-of-8 pattern, labial adhesions, atrophy of labia minora, loss of clitoral hood with narrowing of the vaginal orifice. Unlike lichen planus, lichen sclerosus does not involve the vagina and cervix. When investigating complaints of pruritus vulva or abnormal vaginal discharge, besides the standard gynecological history, the following details should be established: drug and medical history, including drug allergies, psychiatric history, sexual history, previous abnormal cervical cytology or HPV infection, family history of atopic conditions, autoimmune diseases, history of urinary or fecal incontinence, personal habits and hygiene of the patient. Examination of the vagina, cervix, and perianal skin should be made where intraepithelial neoplasia or a malignancy is a possibility. Detailed examination should also be conducted to see if vulval lesions are present, and a full body examination done to find evidence of related dermatosis. For cases with lichen sclerosus, vulval biopsy will show epidermal thinning, the horny layer will be unchanged or hyperkeratinized with disappearance of the reed pegs. The dermis is edematous with some degree of hyalinization and collections of round cells. General measures include using a bland moisturizer or an emollient like aqueous cream, use soap substitutes with water, taking a shower instead of a bath, avoidance of potential irritants, avoid shaving as this can lead to bacterial infections. Specific measures include the following: Treat the underlying cause and manage the symptoms better with a mild steroid ointment or cream for a short course. Long durations of topical steroid treatment are not encouraged, as this may cause vulval skin thinning. Antihistamines can be prescribed to help with itching interrupting sleep. Women with lichen sclerosis have a lifetime risk of developing invasive vulval cancer of about 4 to 9% and should be reviewed regularly. The same general measures may be prescribed together with bland emollients and clobetasol propionate for local application. Abnormal vaginal discharge can result from a range of different factors, including physiological, infective, and malignancy causes. Let's take a closer look at some of the commoner ineffective causes of abnormal vaginal discharge. Most women have Candida as a commensal organism in the vagina. This is also commonly known as thrush. Symptoms arise when the natural environment is upset and Candida multiplies. About 5% of women will have recurrent infections, that is, 4 or more infections per year. Over 90% of cases are caused by Candida albicans, and the rest is due to Candida species like Candida glabrata, Candida krusei. The following conditions increase the risk of getting thrush infection: chronic use of broad-spectrum antibiotics, immunosuppression, HIV infection, diabetes mellitus, pregnancy, vaginal douching, bubble baths, shower gel, tight-fitting undergarments, underlying dermatosis, example, eczema. Clinical features of Candida include discharge that is curdy, thick and white like cottage cheese with a yeast odor, but may be thin and watery or odorless as well, vulvovaginal itching, dyspareunia and dysuria. In severe cases, the whole vulva area is red, swollen and fissured. The diagnosis process for candidiasis is a vaginal swab for microscopy and culture. The presence of more than 10 yeast colonies confirms the diagnosis. Asymptomatic women do not require treatment. General rules for all infections include the following: patients should avoid local irritant, douching, perfumed soaps and bath gels, and tightly fitting garments, and avoidance of intercourse until the infection has cleared. Specific measures for candidiasis include topical antifungals like clotrimazole, iconazole, miconazole, itraconazole should be used as vaginal pessaries for 1 week. If vaginal treatment fails or oral treatment is preferred, a single dose of fluconazole 150 mg is effective. BioLive yogurt is not proven to be effective. In patients with recurrent symptoms, we need to exclude diabetes and assess for underlying risk factors. 150 mg of oral fluconazole every 3 days for a total of 3 doses, followed by 150 mg weekly for 6 months, can be prescribed. Ketoconazole may also be used, but the risk of liver damage is present. Oral treatment not recommended during pregnancy. Bacterial vaginosis affects about 10 to 20% of women. Normally, about 60% of the lactobacilli in the vagina produce hydrogen peroxidase, but in cases of bacterial vaginosis, only 6% do, which results in the rise in vaginal pH. This causes an overgrowth of anaerobic organisms like Gardnerella vaginalis, Mycoplasma hominis, Bacteroides, Prevotella species, and Mobiluncus species. It is also associated with an increased risk of preterm labor in pregnancy, late miscarriage, preterm pre-labor rupture of membranes, and postpartum endometritis. Around 50% of women are asymptomatic. Symptoms include an offensive, fishy, thin, watery, white or grey discharge, particularly after sexual intercourse. 3 out of 4 features based on Amsel's criteria should be present to make a diagnosis. 1. Characteristic thin, white, homogeneous discharge on examination. 2. Vaginal pH more than 4.5. 3. Presence of clue cells on microscopy. Clue cells are vaginal epithelial cells so heavily coated with bacteria that their borders are obscured. And 4. Release of a fishy smell on adding an alkali, such as 10% potassium hydroxide. General measures for bacterial vaginosis treatment include prescription of oral metronidazole single dose 2 grams or 400 milligrams twice daily for 5 to 7 days, or a vaginal pessary containing metronidazole and nystatin daily for 7 to 10 nights. Trichomonas is a sexually transmitted infection caused by Trichomonas vaginalis found in the vagina, urethra, and paraurethral glands. Trichomonas infection in pregnancy is associated with an increased risk of preterm labor and low birth weight infants. 50% of women are asymptomatic, while others experience symptoms including yellowish-green vaginal discharge, which may be thick, thin or frothy, soreness, itching and inflammation around the vagina, dyspareunia and dysuria, lower abdominal discomfort and pain. The classical appearance of a strawberry cervix due to punctate hemorrhages is found in 2% of cases. Diagnosis for trichomonas includes the following: direct microscopy of vaginal secretions, vaginal swab for culture, or nucleic acid amplification test, which also tests for Candida albicans and Gardnerella vaginalis simultaneously. Management for trichomonas include offering screening for coexistent sexually transmitted infections, prescribing metronidazole 2 grams orally single dose or oral metronidazole 400 milligrams twice daily for 5 to 7 days. Same treatment is given for pregnant women. All intimate partners in the recent past 4 weeks should be notified and screened for sexually transmitted infections. Treatment should be given irrespective of investigation results. Avoid intercourse until infection is cleared. Cervicitis refers to inflammation of the cervix and is diagnosed clinically by the finding of mucopurulent discharge at the cervical os and endocervical canal. Sexually transmitted infections like chlamydia, gonorrhea, trichomoniasis and herpes, as well as use of intrauterine copper device and allergy to condoms increase the risk of cervicitis. Majority of cervicitis patients are asymptomatic, while others may experience symptoms like postcoital bleeding, purulent vaginal discharge, dyspareunia. Clinical examination reveals purulent discharge, erythema of the cervix, inflamed and swollen vagina. A bimanual examination is mandatory to ensure there are no uterine or adnexal tenderness or masses suggestive of pelvic inflammatory disease. A cervical smear is required for cytology and screening for sexually transmitted infections. Rarely, colposcopy for pre-invasive lesion or a cervical biopsy is required if an underlying malignancy is suspected. Antimicrobials should be prescribed for bacterial infections. Persistent symptoms after completion of medical therapy can be treated by cold coagulation or laser ablation. Thank you for watching this video. This video is presented by Yonglulin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.